Welcome to this event, COVID-19 in Prisons, Preparing for Future Pandemics, hosted by the Centre for Crime and Justice Studies. I'm Matt Ford, Research Analyst at the Centre. I've been leading on our work on COVID-19 in prisons, which we began in March 2020. This is the third and final webinar in a series on COVID-19 in prisons, funded by the Hadley Trust. I know that many of you attended the other webinars in this series, but I'll just recap what they were about and how this one fits in. So the first webinar we held in this series was in early December 2020 and discussed the impact of COVID-19 on prison systems in England and Wales, Scotland, France and Italy, with a particular focus on the impacts on the size of prison populations, as well as the dynamics behind those changes. We held the second webinar in March 2021, which assessed the response to COVID in prisons in England and Wales, as well and abroad, and some of the learning which had emerged. Now we're looking how to take forward that learning from this pandemic to prepare for the future and talk about what needs to be in place to prevent and manage pandemics in prisons, including how we ensure that public health is prioritised and how we might hold the government to account where we don't think public health has been the priority during COVID. We are focusing on England and Wales as a jurisdiction today, so we don't have the kind of international focus that the other two webinars have had. So who's going to speak to these issues? We have four excellent speakers with us today from public health and social science backgrounds, who I'll introduce in turn. As many of you have already attended these events in this series, you're probably familiar with the format by now, but I'll recap anyway. Each speaker will talk for no more than 12 minutes each, and then once all of our speakers have given their presentations, we'll have a question and answer session. Please add any questions or comments you have throughout the event in the question and answer box and upvote the ones you would like to get asked in the Q&A session, where I will field them to speakers. So the Q&A session is led by our audience. And please do that, throughout the event when you're listening to speakers, just pop the questions and comments you have as we go along. We will be finishing at 11 AM. I won't keep you for any longer than I've said I would. We now have about 120 people in the audience. So I will move to introducing our first speaker, and that's Dr. Eamonn, who's National Lead for Health and Justice at Public Health England and Director of the UK Collaborating Centre World Health Organization Prisons Programme for the European region. He's going to speak about his work on the prison population management strategies in England and Wales, the vaccination programme in prisons, current challenges and developments in the response to COVID in prisons, and planning for future pandemics. Over to you, Eamonn.
Thanks so much, Matt. I'll just share my screen and bear with me. So could you just confirm that you can see that?
Yeah, I can see that, Eamonn. It looks good.
Perfect, thank you. So, well, good morning, everyone, and thank you very much for the invitation to present today. I'm very pleased to be part of this discussion and this audience, and very keen to share the work that we've been doing in Public Health England in partnership with the Prison Service and NHS England in protecting some of the most vulnerable members of society from the impacts of COVID-19. Sorry. So as we went into the pandemic, the challenges we faced was one, a novel virus, which was known to be causing severe acute respiratory infection against which there was no pre-existing immunity in the population. And so there were real concerns about the potential impact of this virus in many places, but no less so than in prisons, where our primary concern was that we might face explosive outbreaks. In March 2020, modelling work that my team led suggested that in an unmitigated, reasonable worst-case scenario, we could expect more than 77,000 COVID-19 cases and up to 2,000 deaths in people in prison in England and Wales, if that explosive outbreak scenario was to be seen. This would be impactful not only in prisons, but also would have an impact on NHS services for the whole community. There was also a concern about whether prisons could actually be a source of infection for the wider community, given their propensity to cause disease amplification. And so there were big conversations at the time about how best to mitigate these risks, including conversations about whether prison populations should be decarcerated as part of pandemic mitigation. When we think about the risks in prisons, it's useful to consider different hazards that are seen because of the fact that these are closed settings with vulnerable populations. What we've certainly had the lived experience through this pandemic to prove is that there is a close association between the level of infection in the community and the risk of infection in prisons. And this is what we call the ingress hazard. And it relates to the fact that particularly prison staff moving between the community and the prison may unwittingly be a vector of infection, particularly as we learned during this pandemic the importance of asymptomatic transmission, which was an evolving understanding as the pandemic continued. Because in prisons, people are at close quarters and there is close regular contact between people, there is then this transmission hazard. And of course, because this is a closed setting, that quickly translates into an outbreak hazard. And then finally, the consequences of that really are about how you have a vulnerable population with underlying medical conditions, including age. As we know, the prison population in England and Wales has been aging over the last number of years. So you have a risk for severe outcome. At the side of these graphics, we have the mitigations that we have evolved in response to each and every one of these hazards. But you will see that the common thread across all is vaccination, and we'll talk about that shortly. But one of the primary interventions that we evolved very quickly at the start of the pandemic, and in the absence of many other interventions, including very limited testing and no vaccination, was a population management approach that we designed in Public Health England that was called compartmentalization. The basic idea behind this is to enable you to manage a population so that you reduce the risk of all of these hazards, particularly that of ingress and transmission and outbreaks. And that evolved a number of strategies, including the development of reverse cohorting units, or RCUs, which were places where people could be received from the community safely, held in isolation for 14 days before being transferred to the general population. Shielding units were evolved to protect the most vulnerable, the clinically extremely vulnerable, and had enhanced amount of biosecurity around them, including non-cross deployment of staff and extra measures to avoid mixing with other parts of the population. People who were symptomatic or diagnosed with COVID were put in protective isolation. And we also managed down as far as possible into prison transfers to prevent the seeding of infection from one prison to another. And as the pandemic evolved, so did our mitigation. So in line with national lockdowns over the course of the pandemic, the regime in prison was modified. And at many points in this pandemic, this has been some of the most challenging areas of our response to manage, because it's a fine balance between protecting people from infection and supporting their health and well-being and rehabilitation. But it resulted at various points in the pandemic in significant restrictions of social visits, restrictions on access to education, training and employment, access to gyms, religious association and so on, and also population management by managing down the number of people unlocked at any one time and trying to promote social distancing, although any of you have spent any time in prisons will know how difficult that is. We also strongly advised against intra and inter-prison movement, because that was a concern about seeding of infection, as mentioned, as well as staff cross-deployment. During the time of the pandemic, we also started from a very low base with testing, where testing was limited to primarily symptomatic people at the start of an outbreak, and for the first few cases only, to one now where there is a very large program of testing of asymptomatic staff and prisoners, particularly focused around prison movement, and also the use of PCR and LFD testing and laterally whole genomic sequencing. So over the course of the pandemic, we have seen significant impacts, although thankfully not at the level that we feared at the reasonable worst case scenario in 2020 in March. And although each and every death is a tragedy, Thankfully, we've seen a relatively small number of deaths from COVID so far, with recorded 131 cases among prison service users to date. The shape of the pandemic is also of interest because you can see that it generally mirrors the evolution of the pandemic in the community. And like the community, the relative size of wave one is actually impacted by that issue of testing. So wave 2 or 2 and 3, depending how you want to interpret this graph, we had much more testing available, so we're able to confirm infection in symptomatic patients, and therefore it is an apparent larger wave. But when we look at the actual outbreaks, and this is recent data, and compare the situation in April earlier this year with the most recent data last week, we can see that two things have happened. Firstly, the overall number of outbreaks has thankfully gone down. And at the time of preparing this slide, there was only one. And also, we're seeing that most places have got now very significant reductions in the number of cases associated with outbreaks. So at one point in the pandemic, when we had the highest number of cases, we were seeing some outbreaks recruiting over 200 cases, which of course is very close to the explosive outbreak scenario. Similarly, we've seen the risk of death among both residents and prison staff track the pandemic experience, with the overall experience in wave 2 being worse than wave 1. Vaccination, as I mentioned earlier, is the one intervention that is a mitigation against all hazards. At the time I was preparing this slide last week, at that point, the JCVI recommendations were for people aged 25 years and over, as well as those in clinically vulnerable groups, to be offered vaccine. But of course, events have moved swiftly in the past few days. And now we hear that people from the end of this week, aged 18 and over, will be offered an opportunity for vaccine, with ambitions that every adult in the UK has a vaccine, at least the offer of first dose vaccine by the 19th of July. We, of course, have had a debate, many of us, about the option to have a settings-based approach to prison vaccination. JCVI, when they reviewed the case we made, disagreed with the need for a prison setting-based approach, but promoted the idea of ensuring that all of those people in prison who are in the appropriate age and clinical cohorts should be offered vaccine in line with the program in the community. And that has been the way that the NHS has proceeded. We have estimated, though, that in order for the protection against outbreaks that we want to see to be delivered through vaccination, we need to have a coverage in prison residents of over 90% and prison staff of over 80% for first dose. And while this is modified by second dose, it is still an important aspiration and a milestone that we think we should get to very quickly in order to protect people. So far, the NHS has been delivering the vaccine program in the prison since January this year. There was a delay compared to the community because of the need to use the AstraZeneca vaccine rather than the Pfizer, because of logistical challenges at the start of the vaccine program. And then, of course, during the evolution of the program, the advice about avoiding the AstraZeneca vaccine in younger people came to the fore. And so Moderna vaccine was used instead. But if we look at the coverage, those aged 30 and over in our prisons, 51% have now received first dose vaccine and 30% have received second dose vaccine at the time of this data shot last week. Of course, the Delta variant has emerged in the meantime and is now predominant in the pandemic at this moment in time. The concern about the Delta is that it's more transmissible, may be associated with more hospitalization. And in terms of vaccination, it's now recognized that 2-dose vaccines are really required in order to get the best protection. So at this moment, our challenges include building a capacity to deploy mass testing in response to outbreaks, driving up testing opportunities for staff and residents, key concern is getting the vaccine coverage up to the levels we described of 80% staff, 90% residents as quickly as possible. But we're also looking at new testing technology, including wastewater analysis for early warning. And of course, it's all about balancing risk and harms, including addressing the backlog of health needs that have built up in prisons as well as the NHS. Finally, thinking about what we need to learn from this pandemic to prepare for the future, it really is important that prisons should be part of integrated planning, exercising, training and response from the start, so that we ensure that this learning is captured and also fed into future preparation. Prison issues need to be part of public health surveillance systems. So too often the health issues in prisons are not reported routinely. And this is a real problem because it means that we're flying blind a little to the impact of infections in prisons in many jurisdictions. England is uniquely well placed though, because we've had this surveillance during the course of the pandemic, unlike other countries. There needs to be thought about prison population management, particularly the issue of reducing overcrowding and even considering alternatives to custody as part of the measures to drive down prison populations as mitigation against large outbreaks in the future. And of course, we must improve prison healthcare services so that we have support for that unmet health need that has emerged during the pandemic, as well as support from the impacts of the pandemic, including long COVID. And finally, we need to consider, again, a settings-based approach for vaccinations for any future pandemic and make sure that prison needs are put at the front of the queue when we start to consider protection of the population generally. Thank you.
Thanks for that, Eamonn. Loads of really good information in there. I'll remind attendees that this event is recorded and we'll be sharing that video afterwards. So in case you need any of that for reference. The Q&A is filling up nicely now. But I'll just remind people, if you have any thoughts, comments, questions about what Eamonn has said and what our other speakers are going to say, then just please pop it into the Q&A. So we can have the question and answer session once all our speakers have made their presentations. Okay, so our next speaker is Chantal Edge, who is a Public Health Registrar and National Institute of Health and Research Clinical Doctoral Research Fellow at the University College London. And she's going to speak about digital equivalence in health services in prisons. Over to you, Chantal.
Thank you, Matt. Let me just share my screen as well. See if we can put that onto slideshow. Sorry, the top of the Zoom bar is covering my controls. There we go. Can you see that fine?
Yeah, that's good, Chantal.
Perfect. So thank you, Matt. So yes, I'm a research fellow that has been researching prison telemedicine, which is essentially video consultations in prisons for hospital care. My research covering the period before the pandemic and also during the pandemic. And I want to think today about some of the lessons that we've learned and how these could apply to future pandemic planning in the context of digital equivalence. So, as we're all aware, technology was a bit of a lifeline during the pandemic lockdowns, whether people were using it for socialising on Zoom calls, attending school classes or university lectures by video, doing more Teams calls than we could ever imagine for work, or seeing your GP or your hospital doctor by video. Many of us use it as a bit of a lifeline. And of course, we were prepared. Most of us had some sort of access to digital technology. A lot of us have Wi-Fi, a lot of people have smartphones or access to work computers, or at least access to 4G networks. But of course, this wasn't the case in prisons. There isn't Wi-Fi networks. 4G was illegal. Use of devices for people in their cells was very, very limited, which really set us on a back foot. So there are a lot of very good reports about what life was like in prison during the lockdown, but I've just picked out a few quotes here from the summary of the overarching HMIP report about what happens to prisoners in a pandemic. And all of these quotations, I think, could have been, at least in part, mitigated by better use of digital technology. So things such as isolation and lacking social interaction or purpose, boredom, lack of ability to access resettlement staff or rehabilitation activities, limited or suspended healthcare, lack of education, no family visits, and where technology was introduced, technical glitches. And of course, the prison service did move hell and high water to try and get technology in. They rapidly rolled out a video visit system, and they supported us with healthcare approvals, which I'm going to talk about. But the problem is that this technology wasn't already in place. We hadn't really tested it to iron out those glitches. We hadn't got it normalized and part of everyday use. And again, this put us in a back foot sort of situation. So I'm going to talk now about the health case study to kind of frame these issues. And it's one I'm very familiar with because it's about the video consultations work. So before the pandemic started, I'd been working with the HMPPS central digital teams for a period of around 2 years to get a software approved to do video appointments between hospitals and prisons in Surrey, where I live. And it had taken this long because although it's NHS software, it has to abide by the digital audit and security rules of the prison service. So we got this software approved just before the pandemic started, and there was one other software approved for use in prisons in the north, which meant there were 2 options on the table. And this meant that NHS England and NHS Improvement were rapidly able to purchase a number of licenses for this software and roll them out across the secure and detained estate. And then we had a further quick win. In fact, it was kind of unbelievable. So when we approached the digital teams and said, look, we're a little bit worried. The prison healthcare departments in the prisons generally have internet that's so slow we can't do video calls. And a lot of people are going to be confined in their cells. What can we do? And they said, you need 4G. You need a tablet device you can move around the prison. And they changed the law in 4 days over a weekend to allow us to use 4G devices for these video calls. It was really quite remarkable. We had to get the tablets built bespoke. We had to make sure they're very secure, but we did. And we ended up rolling these out along with the software to every single prison, immigration removal centre and part of the children's estate in England over a period of 5 months. So we felt like we'd reached the top of the mountain. We were so pleased. We got this equipment out there. It had taken years before. We never dreamed we'd get approvals for 4G tablets. And in fact, I think we probably wouldn't if there hadn't been the pandemic behind us. But of course, we were soon to find out that that was only mountain 1. Quite quickly, mountain 2 loomed on the horizon, and we're still climbing. And that's getting our healthcare staff to use it in the prisons. Quite simply, staff would much prefer to do what they've been doing for years, even if it takes a couple of minutes longer, then learn how to use a new piece of digital technology, find the password, sign the device out, etc., etc. And we should have known a bit better. There is a whole wealth of healthcare literature that talks about digital technology in health and how tricky it is to get people to adopt it and to make it part of their normal everyday use. We're now at the point where staff know what the software name is, they know what it's for, they understand what it's for and they actually buy into what it's for, and they're starting to think about how to use it, getting digital champions and all sorts. But it's taken time, and it's going to continue to take time for it to really embed and get used properly. And now there's mountain 3. And I'd say we're not even halfway up mountain 3. So like I said before, when I started doing this work before the pandemic, it was all about trying to connect to hospitals for video consultations with numerous benefits to patients, to prisons, to hospitals, if we can do some of this virtually. And as Eamonn alluded to, we're now looking for the recovery agenda. We need to catch up on all these appointments that have been delayed. And hospitals is a key area of focus. But of course, if we're finding trouble getting our staff in the prisons to use it, you can imagine how hard it is when we go to a different organisation. Now, at the start of the pandemic, NHS Digital offered free software to every hospital trust in England for them to try and use video consultations. But this software did not meet the security approvals of HMPPS, and prisons are not allowed to use it. However, you can imagine how the conversations go when the prisons approach the hospital and say, we know you've got a software, but we're really sorry, we can't use it. Please, can you use ours? And the hospitals tend to think, it's a big ask for what's really a tiny, tiny part of our patient population. And even if we do get past that, we're often getting stuck on technical areas or issues such as getting the appointment link into the right consultant's diary on the right day during the right clinic. And it's becoming more of an IT project than a patient quality and safety. So that's a mountain we're going to continue up, I think, for some time. And just to think how it could have been if we'd been ready. So I'm going to compare here a little bit of data from England and Wales to Texas. And I'm familiar with Texas. I went to visit them as part of my fellowship because they've been doing video consultations in their prison population since the early 1990s. So they have a prison population which is roughly double that of the English and Welsh population. And in 2015, which is the most recent data I could find online, they did nearly 132,000 video consultations. The Nuffield Trust analysis that's been done recently of hospital data in England and Wales shows in the period 2017 to 18 in England, there were 842 telephone or video consultations in prisons. Yes, the Texas ones will include GP appointments as well, but still they were way ahead. They could hit the ground running, and they did. They used their video system to great effect during the pandemic, but we simply weren't ready. Another part of a case study, a secure tablet option that's been rolled out to a jail, again in America. With tablets that are connected to a secure intranet or Wi-Fi, people can access library, podcasts, music, job search software, brain teaser, and even use the tablets as a phone. It's all completely secure. They're returned to the prison at the end of the day and charged. I've seen the security they use in America. If they can get something they're happy with, then I'm really sure we can over here as well. So simply put, my one take-home message from this is, we cannot wait until another instance where prisons are shut off from society to prompt and fund widespread digital innovation. There are many reports before the pandemic, there are more coming out now, talking about how far behind our prisons are in terms of digital technology use. The community has gone light years ahead during the pandemic, and it's widened the gap. It's increased the inequivalence between prisons and the community. We need to catch up, and we need to keep up. So what could we aim for? And this is by no means an exhaustive list, just a couple of thoughts. Secure Wi-Fi, a game changer. We could have these type of in-house tablets. We could put our 4G tablets on the Wi-Fi. Another learning point for us is that concrete and iron heavy buildings are not conducive to good 4G signal. Glitch-free video visits. I know the video visits option exists, but a lot of reports have said at the moment it's not quite there yet. We don't want it to freeze or cut out in meetings. We also don't want to replace in-person visits with video visits, but having the option there for if future lockdowns do happen, or if people can't travel a long way for an in-person visit one day, is a good thing to have in the back pocket. In cell technology, again, pilots are rolling out. We need to widen that, give people consistent access to education, entertainment, rehabilitation activities. Digital healthcare, wider than the video calls, apps, wearables, in-cell monitoring. And can we use our digital technology to bring through the gate, behind the gate? Could we connect people by video to their substance misuse team or mental health services before they leave? Help with job appointments or resettlement activities such as housing support. And what do we need? We need adequate funding, but we don't just need funding for the equipment, we need funding for the implementation and the normalization activities, incredibly, incredibly important. We need to make sure that the digital policymakers don't forget about prisons. If NHS Digital had picked a software that could meet all the security requirements of the prisons, we could have used that for hospital visits. Support for digital research. We don't want to widen inequalities or produce bad outcomes through using digital technology. We need to check that it's a good thing. But getting research permissions in prisons is hard enough, let alone getting permissions for your digital technology or intervention at the same time. We need to build this in and we need to make it a priority. Digital literacy. We don't just want to do technology to people, we want to make sure they understand how to use technology when they leave prison and have to do it themselves. And really and finally, we need to be aiming for at least digital equivalents to what's happening in the community. So I'm going to leave you here on a final note with a quotation from a paper we wrote about this very topic, where we said, prisons are already behind the accelerating curve of community implementation and risk falling further behind, bringing even greater patient disadvantage if momentum is not maintained. So like I said, we've got to catch up and we've got to keep up. Thank you.
Thanks, Chantal. Thanks for that. So again, lots of interesting stuff there. Hope people have stimulated lots of questions and comments people might have. We already have a few questions about what could have been done differently in the strategy to tackle coronavirus. We have a few questions about vaccination and why, for instance, prisons weren't prioritised. We have a few questions about the impact that COVID has had on things like rehabilitation and resettlement. There's a few data questions as well. So it's looking good in the Q&A, and I'll be fielding those questions to speakers in the Q&A session. But for now, we have our next speaker, which is Nasrul Ismail, who's a lecturer in criminology and social policy at the University of Bristol. And he's going to set the context for discussions on the record of government re-COVID and ideas on how they can be held to account based on his work on the impacts of austerity on prison health, as well as his work on prison governance issues. So over to you, Nasrul.
Thank you, Matt. I'm just going to share my presentation. Okay. I hope that you can see my screen right now.
Yeah, it looks good, Nasrul.
Okay, great, thank you. First, I would like to express my appreciation to the Center for Crime and Justice Studies for inviting me to speak at this event. It is a pleasure to be here today. The theme of today's webinar is future strategies for preventing and managing pandemics in prison. To best contemplate the future, we must reflect honestly on the past. My presentation will scrutinize whether the government has met its 3 objectives as outlined by the Justice Minister, Robert Buckland, in managing the spread of COVID-19 in prisons. My focus will be on England and Wales, although I expect what we glean from this scrutiny will also apply to Scotland and Northern Ireland. The first objective of the government is to preserve the lives of prison staff, the public, and prisoners. Prisons have avoided the worst of predicted results, which was that 6 in 10 prisoners become infected with the virus, leading to a death rate of 1% across the prison population. While the 193 deaths and 16,000 positive cases as of the end of April this year were a better result than expected, these occurrences were mostly avoidable. Still, though, the government has remained reluctant to exercise its discretion in releasing certain non-violent offenders, even as doing so could have lessened overcrowding, a key risk factors for containing coronavirus outbreaks. The government released only 8% of 4,000 individuals who had been identified for early release, which equated to 316 individuals. And the number of pregnant women released from prisons was also very low. The Secretary of State for Justice has also abided a duty to maintain public confidence in the criminal justice system. This consideration is, however, peculiar, especially in that the decision not to release eligible individuals endangers prisoners, prison staff, and the public. The second objective of the government is to maintain the security, stability, and safety of the prison estate. To do so, a few rehabilitative initiatives were introduced. For example, video calling facilities generated over 20,000 calls as of September 2020. Prisoners also received learning materials and in-cell activity packs. But why were such initiatives not introduced earlier, before the pandemic? The Farmer Review in 2017, for instance, recommended video calling facilities, but such facilities were not implemented until 3 years later. For certain other prisoners, the lack of access to rehabilitation affects their prospects of release, because they might not be able to demonstrate to the parole board that they have engaged in activities that will reduce their risk to the society. Finally, violence in prisons has manifested itself in a different form. Although the latest statistics show fewer self-inflicted deaths of reduction of 4%, a reduction of 53% in assault cases, and a reduction of 15% in self-harm cases, the latest HM Inspectorate of Prison report finds that accrual of debt persisted, and some prisoners resorted to drugs to cope with isolation and boredom, thus encouraging more violence, bullying, and intimidation associated with illicit activities in prisons. We also know that the official statistics were under-recorded prior to the pandemic. This discrepancy has continued during the lockdown period, and minor acts of self-harm, for example, might not be noted due to fewer prisoner-staff interactions. The final objective of the government is to provide sufficient capacity to meet overall demand for prison places. Thinking critically about this objective, it seems to promote institutional preservation rather than human survival, given the pre-pandemic dependency on prisons as a crime control mechanism. The prison population diminished by 6% at the end of March 2021 compared to the year before. The buffer was provided in part by suspension of hearings for criminal cases. Although with this lever no longer in place, the government has continued to expedite cases. We must therefore ask, is the objective of COVID-19 protocol in prisons one of disease control, or in fact, population control? Moreover, why must this objective conflict with the objective of preserving life? We are in fact witnessing how governance through the pandemic has engendered additional neoliberal reforms, such as the police, crime sentencing, and courts bill, which will lengthen sentences and further inflate the prison population. Additionally, earlier this year, the government announced the creation of an additional 500 places for women in prison. Providing sufficient capacity for prisons require adequate staffing and resource allocation. The prison system is, however, already overwhelmed owing to these investments due to austerity that lasts to this day. So, how can we require accountability from the government in managing COVID-19 cases in prisons? There are 6 ways I believe we can require accountability from the government in its management of COVID-19 in prisons. For maximum impact, these options should be mobilized together. The first one is to reactivate oversight mechanisms. The announcement from HM Inspectorate of Prisons that it will resume full inspections following last year's short scrutiny visits is welcome. Although it is reasonable to assume that lockdown affected the visits, future strategies should focus on gathering information without in-person attention, perhaps involving a channel to gather feedback from prisoners' family members, or some means of collecting anonymous tips from the staff. It is also about encouraging advocacy organizations to continue demanding transparency and accountability. The Howard League for Penal Reform and the Prison Reform Trust, for example, have undertaken a Herculean task in regularly calling on the government to reduce the prison population since March 2020. They have even threatened legal action over the government's failure to release more people from prisons during the pandemic. This activity sent a clear message stressing the need for transparency and accountability during a global emergency. It is essential that others, including academics, join these organizations through various channels, including publications and the media. I also urge advocacy organizations to have a contingency plan for gathering intelligence from prisoners to ensure that the data flow freely and scrutiny is maintained even during a lockdown. It is also about encouraging judicial review of cases. Prisoners can bring cases challenging conditions, as can their networks and advocacy organizations. Such actions would be akin to the Good Law Project legal challenge over the government's award of PPE contracts. The point would be to determine whether the government's action amounted to illegal treatment, procedural unfairness, and irrationality. Further considerations could also be proceeded in the light of the principles of the European Convention on Human Rights, particularly Articles 2 and 3. Have rights been inappropriately restricted under the pretext of public emergency? It is important to carry on research that demonstrates a link between infections in prison and the spread of COVID-19 within the community. A March 2021 COVID-19 outbreak at HMP Sudbury, for example, was linked to an outbreak in a rural area of Derbyshire. Additionally, new research by Towers et al. Illustrates a link between COVID-19 outbreaks in US prisons and corresponding outbreaks in surrounding communities. Academics and industry researchers must harness these findings and mobilize arguments to advocate for reducing the prison population in the interest of saving lives, promoting social justice, and saving government money in the long run. It is also important to reiterate to the public that releasing certain offenders from prison does not increase crime. A 2016 study looking at prisons in California showed that releasing 30,000 incarcerated individuals per year did not increase the whole city's level of crime. And in Russia as well, they released more than 100,000 children in prisons, as well as adults convicted of a minor crime within a year, and did not see an increase in crime throughout the country. And finally, it is important to amplify the voices of the lived experience, namely the prisoners themselves. It is encouraging to see emerging literature has been documenting prisoners' experiences living under COVID-19 restrictions, publications by the Prison Reform Trust and by my colleagues in Scotland and Northern Ireland, Matthew Maycock and Ruth Gray, have been great in articulating prisoner stories. COVID-19 protocols often turn prisoners into mere objects of administrative procedures rather than human beings. Amplifying their voices, therefore, would contextualize their experiences and offer direction for future COVID-19 intervention and management. Thank you very much for listening.
Thanks, Nasrul. Again, that was really, really interesting and really, really well presented. So we're very grateful. I'd like to remind people again, just to put more questions in the Q&A box, and also upvote ones that you'd like to hear asked to the speakers in the Q&A session. But on to our final speaker now, and that's Dr. Zubaida Haque, who sits on the Independent Scientific Advisory Group for Emergencies, and she's mainly going to be talking about prisoners being prioritised for vaccination. So over to you, Zubaida.
Thank you very much, Matt, and thank you everybody for joining us today. You've been incredibly patient, so I will try and speed through this. I don't have a presentation, so you're just going to have to watch me and listen to me. I'll quickly start just telling you a little bit about Independent SAGE and why we were set up. We were set up last May by Sir David King, who's a former Chief Civic Advisor under Labour, but has also worked under the Conservative government and actually quite closely with Boris Johnson when he was in the Foreign Department, Foreign Ministry of Foreign Affairs. So yes, so we were set up. There's 12 of us, and I work with 11 scientists. And I was asked to be a member of Independent SAGE because of my extensive background in inequality, addressing issues in inequality, but also in policy making. I worked for a very long time in government. Now, the reason we were set up is because we were concerned that the government were not sharing, if you like, the data and the science behind the pandemic. You know, we know that quite a lot happened during March and April. We know that at the beginning of this pandemic, we now know at the beginning of this pandemic that the government were initially following a natural herd immunity approach until, of course, they were corrected about that approach and made to realize that actually it would have a devastating impact on hospitalizations and death tolls in this country. So we came together because we thought actually we need a buffer, or we need at least someone to explain the science to the public about what's going on, be transparent about the data, but also to highlight where inequalities exist in this pandemic and how they can be addressed best. So in a sense, really, the way we saw it is, and I've used this many a time, which is that we were all facing the same storm in this pandemic, but it became rapidly clear that we were not in the same boat. And I was particularly conscious of that because at the same time, I was also the interim director of the Runnymede Trust, which is a race equality think tank. And I quickly realized, along with my colleagues, that this pandemic would have a disproportionate impact on Black and ethnic minority communities because of pre-existing inequalities. And I guess that's a good place to start with prisons, because we can't see prison populations as well as the workforce in prisons in a vacuum. We have to understand that even before this pandemic, there were many inequalities and many gaps in the system, which meant that prisoners in particular, but also prison officers and the workforce would be not only overexposed to this virus, but also underprotected. And, you know, we've heard quite a lot from Chantal, Eamonn and Nasrul about what some of those inequalities are, ranging from inequalities or huge issues ranging from overcrowding, huge overcrowding, of course, and we know the virus flourishes in overcrowded settings, but also in terms of sanitation. We haven't mentioned that very much, but I worked in prisons quite a lot in my past, both working with government, but also outside of government. And sanitation is a huge issue in prisons because prisoners don't always get the shampoo that they need, the soap that they need. They don't always get showers when supposed to get them. And it's very difficult to be washing their hands regularly and so on. And in particular, that's very difficult with restricted regimes. And we heard quite a lot about how the prison service moved very rapidly into a severely restricted regime as soon as the pandemic started. We also heard from Chantal what that meant really in terms of the sort of, in terms of the physical and mental health impacts of that in prisoners. And actually that's really important because the population, the general population, of course, we've all experienced the sort of mental health toll that this pandemic has taken on us, and we've experienced long delays and long gaps of not being able to see our loved ones. And that's no different for prisoners, but in some ways it's been much more harsh for them because not only were family visits cut, not only were there gym visits, education and rehabilitation programs cut, but they were also locked up at the beginning and actually for several months, and to this day that's still happening in some prisons, for 23 hours every day, just to protect them, not just to protect, but to protect them from the virus, as though there were no alternatives. And this has been a big problem because there's a big difference between protecting people, vulnerable people, big difference in terms of balance between protecting people and actually rolling out measures which keep them safe. So in a sense, and Eamonn mentioned this as well, you know, mass testing should hopefully alleviate some of those issues, in the sense that the more testing people can have, the more likely we'll be able to identify positive cases quickly, self-isolate their contacts to stop that, you know, spread of transmission, to stop that spread, and to break that chain of transmission. But it also means that hopefully people can resume to their normal activities, which is quite important, in the sense that, as Nasrul mentioned, you know, rehabilitation isn't just important in terms of giving purpose, isn't just important in terms of that's one of the key objectives of the criminal justice system, but it's also important in terms of when you get released. So there'll be lots of prisoners who will not only have had, if you like, the mental or suffered the mental health impact from this pandemic, of, you know, in terms of separation from their families, in terms of even social interaction, limited social interaction, but knowing that also that their release dates might be delayed now because they haven't been able to attend their rehabilitation programs, will also have a mental health impact. And of course, in terms of pre-existing inequalities, we knew that there were already issues around mental health, but also issues around self-harm and violence. And, you know, there's many a quote from previous chief inspectors of prisons who have described prisons as a place of crisis, and a place where, you know, safety and decency had been largely compromised in the last several years. And I saw that myself in prison. So we've got all of these issues. But in terms of the pandemic has exacerbated all of those. Now, coming back to the beginning, the reason I wanted to talk about vaccinations, and Eamonn hinted at it, is because to a great extent, having vaccinations by settings prioritizing places like prisons, young offender institutes, secure schools, all of those places, just generally mass settings like care homes for vaccinations, makes a lot of sense for prisons, not just in terms of logistically, not just in terms of a more humane response, letting prisoners return to, you know, their education programs, to activities outside of the prison, to rehabilitation and so on. So it's not just a sort of a human rights issue. It fundamentally also makes sense in terms of health. It doesn't at the moment make sense at all to be vaccinating prisoners in the same way that we're approaching it with general population, simply because people go to mass settings. Now, in this pandemic, we have tried to avoid having mass events because we know that that is the ideal circumstances in which the virus replicates. And now we're in a situation with the Delta variant, which we've just heard, which is much more transmissible. It's over 60%, it's around 64% more transmissible, more contagious. We know that it's 2 times more likely to lead to hospitalizations compared to the Alpha variant, the variant. And we know that it is now the dominant variant. On top of that, of course, the more you allow the virus to circulate, the more likely you're going to get mutations. And of course, we have logistical issues, which is that it doesn't, if you vaccinate by settings, then you protect everybody, but also you don't have any wastage of vaccines. At the moment, there'll be a lot of wastage of vaccines in the way that they are pulling, and lots of waste of time as they are pulling out people in prisons to vaccinate them and putting them back in, rather than vaccinating by settings. It also makes sense because in terms of inequalities in prisons, there are huge issues around health, the health status of prisoners and the clinical coding of health status of prisoners, which, to be honest, hitherto has been quite poor. So while JCVI might be saying, well, we're going to vaccinate prisoners by age and long-term illness, just like the rest of the population, and vulnerable prisoners will be identified early, that's assuming that vulnerable prisoners have been identified. On top of that, as we know, not all illnesses, not all underlying illnesses are easily identified, which is why, of course, right now, the Prime Minister has delayed stage 4 of the roadmap, because although younger people are less likely on average to be hospitalized and to die from COVID, there's still that risk if there are high rates of transmission, because you've got a lot of the population still exposed, you've got lots of underlying illnesses that haven't been identified, so hospitalizations will go up and deaths will go up. So we've got all of those issues. And that all basically leads to the same solution, if you like, which is it makes sense to vaccinate by settings. It makes sense so that people can return, so that people in prisons can return to their normal regime. It makes sense in terms of prison officers and prison officers taking the virus back to the community, so breaking that chain of transmission. And it makes sense from a sort of duty of care and human rights perspective as well. There's lots of other issues that I have to add, but I'm going to stop there just because I'm conscious that you've been really patient in listening to all of those. But I'm happy to answer your questions. And sorry, no, one last thing I want to say. In terms of vaccine hesitancy, it also makes sense to vaccinate by settings, because some research has shown that the same vaccine hesitancy issues that exist in the community, disaggregated by ethnic minority groups and deprived areas. So we know that for instance, that some Black and Asian groups in the community have been more hesitant with legitimate concerns and anxieties about taking the vaccines. They also exist in prisons, but what research has shown is that if you do vaccinations by settings, that vaccine uptake tends to be higher. I'll stop there. Thank you very much for being so patient.
Thanks, Zubaida. That was excellent, and bringing some of the wider context and some small p political analysis to that. So that was really good. Thank you. If I could ask all of our speakers just to come back on now for the Q&A. So to turn your cameras on, unmute yourselves. Like I say, the Q&A is nice and full. I think the most popular question is one about vaccination. It's also one I think that everyone could probably answer. So it is, what do you think was the reason for opting against the settings-based vaccination prioritisation? The setting of prisons is similar to that of care homes in terms of close contact and health vulnerabilities. Do you think this was a political decision, as it may have been viewed as controversial to prioritise offenders? We start with Eamonn, who has indicated that he'd like to answer it live. Over to you.
Yeah, thank you. So just so people are aware that I also lead the COVID-19 response for adult social care for PHE. So deeply familiar with the challenges of those settings as well as prison settings. It's also a matter of record that we, PHE Health and Justice, advised JCVI in November last year that a setting-based approach for a vaccine program would be an appropriate deployment strategy. For many of the reasons that Zubaida's actually outlined, we agree. There were very significant concerns about the ability to take a different strategy successfully. However, at the time that JCVI made their initial categorization of groups for prioritization of what was then, at the beginning of this, still a rather scarce resource of vaccine, they were guided by the mortality data. And of course, care home settings, unfortunately, had very high levels of mortality. And so they were the setting that was identified as being particularly important. And then used an age-based cohort approach, again, as a proxy of risk of mortality, and then also those with particular clinical conditions. We have re-engaged with JCVI at several points over the course of the pandemic to ask them to reconsider the approach. I have been personally concerned as a public health doctor that despite best efforts, and I know that very many of my NHS colleagues have been working day and night to deliver this, it has proven challenging to get us to the level of coverage that we would like to see in order to achieve the protections we'd like to see. And it's important to recognize that during the last few months, at the height of wave 2, almost every prison in England had an outbreak. And as I mentioned in my presentation, many of those outbreaks were extremely large. So the same healthcare teams that were there to deploy vaccination were also the healthcare teams managing many of the challenges that those outbreaks delivered, so testing, care of patients, etc. So very, very challenging circumstances. SAGE also produced a paper which they sent to JCVI, and indeed my colleague Chantal was deeply involved in that work, again reiterating some of the data about the impact of COVID-19 on prison populations and advising JCVI to consider a settings-based approach. And again, the response from JCVI was that they would still advise progressing on the age-based cohort clinical vulnerability cohort approach rather than regarding prisons as a setting. As we speak here today, as I mentioned, even how rapidly things are moving, when I prepared my slides on this subject last week, we were at an age 25 plus cohort, which of course was now starting to include a very large proportion of the prisoner population. We're now, by the end of this week, supposed to be enabling vaccination for all those who are age 18 plus. So in other words, all adults in the UK are eligible for vaccination. So the challenge to the NHS is now that all prisoners are essentially, apart from those in secure children's settings, all prisoners 18 years older and above are now eligible for vaccination. The challenge is getting it done. Zubaida, just to respond to one of your points around vaccine wastage, I'm pleased to say that actually there's been very little vaccine wastage in the prison vaccine program, and that's because there has been a permissive approach adopted to support if there were a risk of unused vaccines because a particular cohort hadn't got sufficient numbers, to go beyond the age cohort, and indeed also to offer prison staff opportunities for vaccination. However, the amount of times that needed to be used was actually very, very small. So thankfully, from that perspective, that hasn't been an issue. But and my NHS colleagues will know that I have been a critical friend, that I have encouraged them to be imaginative about how we can maximize the opportunity for mass vaccination. And now we have the green light from Simon Stevens to just get on with it. I will be encouraging my friends in the NHS to really accelerate the route. And we have the same commitment in prisons as we do in the rest of the country, that by July 19th, all people in England over the age of 18 should have been offered first dose vaccine. And what's poignant about that date is actually July 18th is Nelson Mandela Day, International Prison Day. And I would really like us to be able to celebrate two things on that date. One is that every person who's incarcerated in prisons in England and Wales has had the opportunity for vaccination. And secondly, that we have all the resources we need to deliver mass testing at pace and scale in response to any emergent outbreaks in order to manage down the threat from the Delta variant. So I will be working as a public health advocate as well as policy advisor to government to ensure that we deliver on that. And I have to say that, you know, as a doctor, as a public health doctor, somebody who's worked in prisons for many, many years, and as somebody who is hitting an anniversary themselves this year of being a doctor for 30 years, I'm certainly convinced that we have both the science and the ethical arguments on our side to push for mass vaccination in prisons. And now we have the operational levers to do it. It will be imperative on everyone to get this right, because we just cannot allow the COVID-19 Delta variant to have the impact that we've managed mostly to mitigate throughout these very long 15, 16 months of this experience. Thank you.
Brilliant. Thanks for that, Eamonn. Yeah, Zubaida, you want to respond or give your thoughts on that question?
Yes, thank you, Eamonn. I mean, actually, it's fantastic. It is fantastic that that PHE and yourself have been lobbying, for the lack of a better word, JCVI to vaccinate by mass settings. It's also quite sad and disappointing that you've been doing that since last November, but to no avail, because it's quite clear that JCVI don't have a very strong argument for not vaccinating by mass settings. Frankly, their response is quite poor. And it's partly because when you look at prison populations have high proportions of Black and ethnic minority prisoners. I mean, in YOIs, we're talking now, I'm sure, about 70%, the majority of young offenders are from Black and ethnic minority groups. And we've always known in this pandemic that Black and ethnic minority groups, for all sorts of reasons, are much more vulnerable to this virus, much more likely to be hospitalized and much more likely to die from COVID. So there are those issues, but also there's the issue that actually right now, under the Delta variant, we know that one dose is not enough. One dose only gives us a third of protection. What we need are 2 doses. So of course, that's in terms of vaccine hesitancy. There are considerations there about really encouraging people to get 2 doses, but we need to start right now. And I'm really concerned that because we're still going by age, and because on average, the prison population is much younger than the general population, it's going to take some time to roll out. And by the July 19th date, what we'll really have is just a partially vaccinated prison population, which is not sufficient. And what we'll still have issues of is unless we prioritize prison officers getting all those vaccinations as well, is the Delta variant going back into communities, and we will have that vicious circle. Eamonn mentioned the outbreaks. We know that at one point in January, there was some 85% of settings had outbreaks, or something like an extremely high number of outbreaks. Now, with the Delta variant, we are in a very similar situation, slightly different as well, because we're vaccinating much more quickly, but it is a race. And in this sense, I think there's a very strong justification for JCVI to reconsider the issue of vaccinating by mass settings.
Brilliant, thanks, Zubaida. Nasrul, I was wondering if you might have any thoughts on that question. No?
No, I don't have any opinion on that. I believe that Zubaida and Eamonn captured that perfectly.
Brilliant, excellent. Chantal, do you have anything to add from what's already been said to that question?
Yes, I guess I have a few insights. As Eamonn said, so I was involved with this SAGE report through nature of the fact that my supervisor, Professor Andrew Hayward, sits on several of the SAGE committees and was tasked with writing the prison report. And I think the sort of the feeling that we got when we were writing it is that JCVI's initial reluctance had been because there hadn't been enough data presented to them around increased risk of mortality or morbidity and hospitalizations, which we definitely clearly had for this new report. And I was at the SAGE meeting where the report was presented, and I would say that SAGE were very, very much behind the information within the report and very strongly said that this must be conveyed to JCVI, who are responsible for vaccine recommendations. And that was sent to them, I believe, at the end of March, and was not really followed up on for several months. And I know that was because there were huge pressing priorities with the AstraZeneca vaccine and the issues with the blood clots and other issues as well. But I think perhaps there would have been, yes, an earlier window to really take hold of that report and look at the data and really think what it means. Whereas now, I think that the fact that we have moved to this situation where we are at the place where we can roll out to most ages, it sort of perhaps lessens the need for them to take a proactive change in stance. So I think there was perhaps a window of opportunity that may have been missed due to unfortunate delays. But I do hope that that data stands when it comes to discussions around boosters, if and when they occur, and booster variants, and what that might mean in the context of the prisons. Another factor that was heavily reported within the report, much of it through Eamonn's advocacy, was the risk, and as Zubaida mentioned, of infections feeding back into the prisons, and the fact that the infection level in the community may be low, but if you build up an outbreak in the prison, it's a prime area for it to seed back in. So even when we think we're out of the woods, prisons can pose a risk back to the community, as well as the huge risks to the residents inside. So I think it's a kind of a watch this space, and I don't think we should let the issue lie.
Excellent, thanks, Chantal. And also, we had an announcement today of compulsory vaccination for social care workers. So I suppose just for everyone who responded there, would you favour that approach for prison staff at this point? We'll start with Eamonn. Well,
as I mentioned, I'm a public health expert advisor to the Department of Health and Social Care in relation to that work. So the context of that was, as we mentioned earlier, the threat to care homes has been both very real and extant. The best defense is vaccination. We know, unfortunately, unintentionally, and through nobody's fault, due to asymptomatic infection, staff have often been the reluctant vectors of infection into care homes. And despite everyone's best efforts, and the NHS particularly, and I want to pay tribute to NHS colleagues who've delivered an amazing program of vaccination to colleagues in care settings, despite all that good work, there is still an unacceptable level of staff not vaccinated in care homes, and this has been a very significant challenge. We, of course, continue as public health advocates to encourage, to support, to educate people about the reasons why vaccination is important. We understand there are very reasonable, real, genuine grounds for concern that many people have about vaccination, but it's our job to educate, advise, and support. Where that hasn't worked, though, it's important to then think about the protection of the most vulnerable people in our care. And therefore, on the balance of risks and benefits, we've advised that mandation mandation as a condition of deployment may be a requirement for those settings. So will that be appropriate for prison staff? Well, the question that I would have in considering that would be, what is the uptake among prison staff as they become eligible, bearing in mind that as we've just been thinking about age structures, many prison staff are actually quite young. I was surprised a year or so ago, well, maybe more than that now, I was at Newbold Rebel Training College for the prison service, and I was at an event and I was suited and booted and walking across the sort of parade ground, and I felt very much my age as I walked across the space and saw all these bright, shiny young faces looking at me and people calling me sir, which was a very unusual experience for me. So I realized that there are very many young people within the prison staff cohort. So they will just now be becoming eligible, many of them, for vaccination. So we will see at a point not too far in the distant future what the level of vaccination coverage is in that occupational group. I would hope we would see very high levels of coverage. We want to have at least 80% plus of first dose vaccine, and ideally second dose vaccine of something around that level, to be confident we've got sufficient mitigation. If we see levels of uptake below that, we will again go through the same process of considering, how do we encourage support? Is it about access? You know, a lot of these questions just simply, people can't get to the vaccine centres, it's inconvenient, the way they work, shift patterns, etc., etc. So we need to make sure that we've provided vaccine in an accessible way. But if after all of that it doesn't work, then it's an option to consider what else we can do to promote this very important intervention to protect the most vulnerable. And as professionals working with vulnerable people, we have an ethical and professional duty to protect those in our care. And I think that applies to many people who work in prisons, whether they're healthcare or custodial officers. And therefore we might have to consider similar. But I would hope that actually what we'll find with the prison system is a very high level of enthusiasm for vaccination. We shall see.
Excellent, thanks, Eamonn. And Zubaida's got a hand up to respond or to answer the question.
Well, yes, so we haven't talked about this very much, but then neither have the government. One of independent SAGE's biggest frustrations with this government is, I mean, essentially they've been like a one-trick pony. So for most of this pandemic, it's been lockdowns. But fortunately, happily, they've moved from lockdowns, but they've literally moved from lockdown, that single magic bullet, according to them, to now vaccinations, as though we have no other tools for keeping people safe. And of course, the government spent some 37 billion in test and trace. And it's great to know from Eamonn that that is now being rolled out in prisons. But that's not the only tools that we have. You know, that there is test, trace, and isolate. But ventilation is hugely important. And I think what I'm concerned about is how that has not been an issue. That's not really been addressed in terms of prisons. We know prisons aren't great places for ventilation, but that would certainly be one way to keep prisoners safer at the moment, you know, and also social distancing. trying to be more imaginative about how, with prisoners, and it's a similar issue in schools, you know, like, which is the government had an opportunity to expand space. You could expand space with schools, have more settings where children can go to school so that they can safely socially distance, have more activities outside, so there's more ventilation and so on. Like, they've had the opportunity. And arguably with prisons, they've also had that opportunity where they could think about improving ventilation, having things more outdoors, so that people didn't necessarily, it didn't have to be all or nothing. It didn't have to be 23 hours in a cell to keep safe. There were other ways of staying safe. And I think we do need to return to that conversation, not just for now, but also in terms of post-COVID recovery. Chantal talked quite a lot about that and what we need to think about in terms of post-COVID recovery. And there are quite a lot of things, as well as IT, but also around ventilation, and also ensuring that if another pandemic hits, that prisoners are not in the same vulnerable position.
So could I just have a quick response to Zubaida's comments? So before the pandemic, I was deeply involved in some of the design work around the new prisons. So people may recall that there was a new prison build program, which was very much what we were engaged in prior to the pandemic. And by design, we were thinking about how the built environment can support and mitigate infections. And in fact, I've been meeting this afternoon with the Royal Academy of Engineers looking at similar work for care homes, and how do we use the physical built environment that thinks about ventilation, that thinks about separation of space, that thinks about how a built environment encourages people to do things. And so all of that is definitely on the cards. And I'm pleased to say that prior to the pandemic, we had been impactful in thinking about the design of some of the new build prisons, and indeed some of the design elements of immigration detention settings. But the reality is that due to a policy decision in the mid-Victorian era, when it was decided not to send convicts to Australia anymore, the new build prison program then is still pretty much the estate that we have now. And so what you have are Victorian prisons in the main, very well designed for the control of people, and based on Foucault's constant observation idea, but very poorly designed for ventilation. And indeed, actually, since the Victorian era, things have actually declined insofar as many of the prisons were initially designed to be single cell accommodation and now are doubling up. So we have had, due to prison population growth and still the same estate pretty much until very recently, increasing pressures on the built environment and doubling up in population issues. So getting a sort of smarter design element built into prisons for the new build prison program is certainly part of the consideration. Adapting the current mainly Victorian stock to the needs of a 21st century pandemic resilience approach is very difficult, but it's not impossible. And it's about considering the whole environment, considering the use of place and space, but some of the physical constraints and how people move and work within the space. So we were having discussions just recently about, could we enable outdoor visiting, so social visiting, and could we enable that to happen in a way that would mitigate some of the infection control risks? But of course, in order to get to outdoor spaces in most prisons, you have to come into the space, through the space, often these sort of corridors and rat runs with trapdoors and so on. And so even doing that is an infection control nightmare. So we have real problems due to the infrastructure and the built environment, and balancing the risks that that brings with the mitigations we can deploy. So it's a devilishly difficult challenge, which, and I think it's important to say this, despite all that, considering what we thought we might see in March 2020 and what kept me awake at night, I promise you, worried about the very severe death rate we were worried we would see, we have, through collective endeavor, and it's not been easy, managed to mitigate the absolute worst of that. But the price has been high, and I just want to pay tribute to the men and women in custody who have cooperated as a group with almost all of the advice and guidance that we've asked them to follow, in the main, very well, largely uncomplaining, but taking a heavy toll. So I recognize that, and I really am conscious of that. But it has been an incredibly difficult year. It has come at a cost. But I would say that we have saved lives through collective effort, but it has been very difficult. And so what we need to learn from this is how to mitigate some of the adverse events that infection control requirements put on us all, and how do we learn from this going forward. And it has to be a very broad discourse, including thinking about the purpose of prison and imprisonment and what purpose it serves. And its purpose must be the rehabilitation of offenders. And how do we enable and support that? Well, you know, there's some very basic issues that we need to consider where infection control and rehabilitation overlap, and it starts with population.
Excellent. Thanks, Eamonn. An important point to finish that little bit on. We have about 7 minutes left of Q&A. So I'll just move on to this next question, which is about future risk. There's a few questions about this in terms of the prison population. Obviously, it's gone down, but there's a corpse backlog and so on. So how do you think the prisons will deal with the potential avalanche of new prisoners as the courts go through that backlog? Do you consider that they will not imprison minor convictions in light of the data from America, with the crime rate not increasing? And I suppose also just what are the implications of, you know, that increase in the prison population, as well as plans for expansion of the prison estate in general and the prison population? Nasrul, do you have any thoughts on that one?
Yeah, interesting question. I think how would they deal with the increasing number of prisoners that might come through from the court? Well, the prison population reduced by 6% during the pandemic. Yeah, I'm not sure really. I'm trying to reflect on that point. The thing is that when you look at, I'm just going to take us back to the CPT report when they inspected the prisons recently. So the CPT recommended a reduction in prison population. This was pre-pandemic anyway. And then the government responded to say it shouldn't be asked to set an arbitrary number in terms of the imprisonment rate. And then they decided to, then they said that, you know, they would increase the prison places by 20,000 places, new places. I'm not sure really, to be honest with you. And I think we're just going to see, you know, absolutely going to increase the number of prisoners, especially when we know that, you know, courts are sitting on Saturdays these days.
Mm-hmm. Yeah. Definitely. Brilliant. Thanks, Nasrul. Eamonn, do you have any thoughts on that about future plans there?
Yeah, I mean, again, it's, you know, I'm a public health doctor, so I stick to my brief, but within the realms of public health advice, I have been consistent throughout the pandemic and thinking about preparing for future pandemics, that a key consideration has to be the size and structure of the prison population and how it's accommodated within the infrastructure we have. So measures which are aimed at driving down population and population density from an infection control point of view are very good. How we consider doing that is a complex question. There are certainly, and we've advocated for a very long time in the public health approach to health and justice, that we need to think about some of the health related and social care related drivers of criminogenic behavior. So recognizing that many people who are in our prison systems currently have a long history of mental health and substance use and physical health needs, recognizing that many of them have a long history of complex social needs, including adverse childhood experiences and trauma, recognizing that interventions for preventing this start at early childhood and require an all of society approach. This is a whole system issue. The prison system is the one place that cannot really turn people away. Unlike other service providers who usually have entry criteria about what they will and won't treat, once a court remands you to custody, the prison system has to accommodate you however they can. A lot of people who come through the doors of prisons in England and Wales and indeed all over the world are there because of a very complex journey, often with high levels of need, and many times that need is unmet. It's a true fact that in prisons in England today, many prisoners receive a higher standard of health care provision and better access to health and social care than they do in the community. So there's a fundamental question here about the appetite we have as a society to address what the drivers are for rising prison populations fundamentally, and whether we're prepared to put the work in to address those. And if the downstream impact is that we then have smaller prison populations, less densely populated prisons, then from a pandemic perspective, we've achieved a win-win. But certainly at the current time, there are real risks within the system due to the backlog of court cases and now courts restarting and so on, that we will see a sort of surge in the prison population again. And this is why bringing all these things together, mass vaccination, we require that. Better testing, we require that. Getting those sorts of measures in place as a minimum are required. But it is going to be a job of work to think in the longer term about how we drive down prison populations, given we've the highest rate in Western Europe.
Can I just, sorry.
No, you go, sorry.
Okay. Can I just add that, I mean, I completely agree with Eamonn that you know, prisons are incredibly complex environments, and the issues there in terms of, you know, health, physical health, mental health, self-harm and so on, you know, have always been there. And I think one of the things I'm a bit worried about is I don't feel very optimistic about what the government will do in this area. I mean, really, at the moment, we're talking about whether they will add fuel to the fire in terms of bringing in, you know, in terms of carrying on with their policy of longer sentencing, in terms of not releasing prisoners, in terms of not addressing overcrowding and so on. But it's great if they don't add fuel to the fire, but I'm a bit concerned about the fact that prisons have been in a dire situation. The very reasons Eamonn and his colleague worried right at the beginning of the pandemic, that there could have been a really devastating impact on prisons. Like, those issues have not gone away. I mean, we have to be honest, one of the main reasons prisoners have been protected was not just because of the extraordinary work Public Health England have done, but also because people were locked up for 23 out of 24 hours of the day. You know, that was one of the key mitigation criteria, that was one of the key mitigation measures that we used. So I think we really do need to put a lot of pressure on ministers not to prioritise politics over public health, as they have done in this pandemic. And I really worry with prisons, because prisons has never been a priority under this government. And I've seen that working in several prisons in the last couple of years. I really do think we need to do much more for them to do what Eamonn hopes they will do.
Brilliant, thanks everyone. I'm just going to quickly, there's quite a few questions have come in for Chantal about digital take-ups. Just want to get one quickly in before we end.
Sorry.
No, it's fine, we've got that, it's fine. So, Chantal, has there been any resistance from anyone in HMPPS of the rollout of 4G and video equipment to assist with healthcare appointments? Also, how can those barriers be overcome?
Yes, there was not too much, actually. We tended to have some resistance from some governors in high security prisons. I think it was a bit of a moment when they were told they could have 4G. But actually, the fact that we'd done this centrally with the HMPPS central digital teams meant we just went back to them, and they went back to the governors and said, why are you worried? We've approved this, we've looked at it centrally, and we're happy with the risks and the management. And actually it overcame all our problems, and no one is reluctant anymore.
Brilliant. Thanks for that, Chantal. Fitted in perfectly with timing as well. So we have 1 minute left. So we've reached the end of our time here today. I'd really like to thank our speakers for their brilliant presentations and contributions to the Q&A session. And I'd like to thank our audience for listening and for your comments and questions to the speakers. Also, thank you to everyone who donated when you signed up for this event. So that money is really helpful for us to keep doing what we're doing. And if anyone else would like to support our work, welcome donations. You can find a link on our website. And as I said at the beginning, this is the third and final webinar in this series on COVID-19 in prisons. But this isn't an issue that's going to go away. We touched on some of that in certainly Eamonn's presentation about recovery, and similarly in Chantal's about about what needs to be implemented in future in prisons in order to reduce these risks in the future. And there is just going to be the impact that has on the criminal justice for a long time to come. There will be inquiries and so on. So we'll probably do further webinars in this area. But we'd like to know your thoughts on what kinds of issues these future webinars cover and what you think we should do. So we'll send a feedback form in the follow-up email after this event. So please tell us your thoughts on what you'd like to see in those events.